Hello, welcome to this presentation, which is jointly presented by Dr. Kerry McNamara of Whole Heart Family Medicine and Dr. Sandeep Chaudry with MedTest. We're going to be focusing on how to improve preventive chronic disease management with a physiology-guided approach. This is taking in much more detailed physiological data to help make better clinically management decisions. I am Dr. Sandeep Chaudry. I'm the Chief Medical Officer at MedTest and have been working here for 18 years. By our background, we were founded in Atlanta in 2003 and are currently serving 52,000 active sites throughout the US and Canada, which predominantly consists of primary care clinics, cardiology clinics, and hospitals. We've tested actually closer to 200,000 patients over the last 18 years and currently average roughly 1,000 per month. We are not a cardiopulmonary exercise testing only service. We're a specialized service, and our biggest asset and value to a practice is implementing our methodologies and expertise that we developed in managing patients in the real world over the last 18 years. In this regard, we also publish cutting-edge research. We provide our services utilizing the cardiopulmonary exercise test, which is a very specialized exercise physiology-oriented test. It's performed on a cycle with continuous blood pressure and EKG monitoring, and we add the mask, which introduces a whole new dimension to diagnostics and prognostics that cannot be had without it. In the mask, we're measuring how much oxygen is being taken up by the lungs, circulated by your pumping heart to the muscles, which goes into the mitochondria through cellular respiration, generates CO2, which is brought back from the muscles to the lungs by the circulation, and you breathe it out. So breath by breath, when we're measuring oxygen and CO2, oxygen consumption and CO2 production under steady state conditions of this test, it equals cellular CO2 and O2 metabolism as well. In the real world, it's used by the specialists to determine the severity of heart disease and pulmonary hypertension and valve disease in patients already known to have these conditions. Diagnostically, CPET, cardiopulmonary exercise test, is actually the gold standard for determining whether exercise intolerance is primarily from the heart, lungs, or other. And if you have a detailed level of analysis that MedTest brings to the table, we can dissect out cardiac into myocardial dysfunction or ischemic patterns, diastolic dysfunction patterns, as well as chronotropic incompetence. So you're going to get much more detailed feedback on the actual mechanism of exercise intolerance. If it's pulmonary, we'll be able to tell you whether it's a circulation or a ventilation issue. The primary goal of every baseline test is to establish peak oxygen uptake at peak exercise capacity as a vital sign for long-term prognosis and management. Peak VO2, which is your oxygen consumption at peak exercise, is the #1 predictor of all-cause mortality and a gold standard in all of medicine. The second goal of every test is to determine the mechanism of exercise limitation, which helps us to guide therapy. Our therapeutic interventions consist of increasing physical activity with customized exercise prescriptions that are generated from each MedTest report in the moderate heart rate zone, which corresponds to heart rates between 40 and 60% of peak exercise capacity. We also use this information to optimize medical therapy with disease-modifying agents such as statins, ACE inhibitors, beta blockers, and SGLT2 inhibitors, as well as picking up more severe forms of disease that can sometimes get missed, but from the other studies, which leads to more subsequent revascularization or valve repair or pacemakers. The goal in every patient is to increase their peak VO2 from baseline, and we're measuring every single milliliter of oxygen per kg per minute. So it's a high degree of precision in calculating the precise exercise capacity, and it's important because if you can increase exercise capacity by as little as 1 milliliter in a healthy person, that corresponds to a roughly 5% reduction in long-term cardiovascular mortality. In patients that have heart and lung disease, the sicker they are, the bigger that number, and ranges from 10 to 15%. So small changes in exercise capacity can have a big change in prognosis, and by providing patients this type of positive feedback when they exercise or add intensified medical therapy, it helps to give a positive reinforcement to help maintain long-term compliance. Where CPET testing fits in the clinical management of patients is actually to just replace the treadmill stress test because it's safer, better tolerated, and collects more accurate diagnostic and prognostic information. So in cases where you would do a plain treadmill or a stress echo with treadmill or a nuclear stress test with treadmill, the treadmill component would be replaced by a more accurate gas analysis system. The benefits of CPET over treadmill are A, functional capacity. Instead of estimating exercise capacity in METs, you're going to be directly measuring VO2, which is a gold standard and is expressed in milliliters per kg per minute, or as percent predicted based on population standards. It's also far more accurate at detecting exercise-induced ischemia based on mechanical dysfunction instead of electrical changes. There's this paper right here we published showed that it's 4 times more sensitive than a stress EKG. Then for exercise prescriptions, it's a gold standard because you can determine the exact heart rate ranges that correspond to 40 to 60% of peak VO2, which is considered which is different in every patient and is considered the best training zones to help stop and reverse disease. And then for serial comparison, what we want to show everybody is, are you same, better, or worse every year? You can only do that if you have baseline data and compare it. So we generate serial comparison reports that makes it very easy to demonstrate to the patient where they are clinically and what direction they're headed, where their trajectory is with serial testing. Aside from measuring peak VO2 as the gold standard for prognosis, diagnostically, the test can help you determine where exercise impairment is coming from, which helps to pinpoint the mechanism of symptoms such as chest pain or shortness of breath, as well as helps you to guide therapy accordingly. So when we analyze the mechanism of impairment, we're looking at multiple parameters, and based on current diagnostic algorithms, the test will come back either based on ventilation or circulation impairment, severely blunted heart rate response with a normal stroke volume response and normal pulmonary function. Those patients need either medication adjustments, or if they're older with severe underlying issues, they become the CI pattern can go unrecognized and they wind up getting pacemakers. If there is a cardiac impairment in general, it could be either systolic or diastolic dysfunction or valve disease, so echo data helps to clarify that. And then if there's a myocardial dysfunction pattern, they have microvascular disease, they may or may not have macrovascular disease, so that we get involved based on peak VO2. We can determine who should go out for diagnostic coronary angiogram first, and if they get revascularized and they come back for medical management. If you got microvascular disease, you still need exercise plus medical management. So the need for this component never changes, and that's where our primary focus is going to be. The 3 diagnostic conditions that we pick up that typically get missed in a cardiologist's office when they send us patients that have normal echoes, nuclears, treadmills, and even coronary angiogram is microvascular ischemia, which is the primary component in MI, non-obstructive CAD, as well as just ischemia or INOCA in non-obstructive CAD. So this is a very common condition. It's a common denominator to progression of all modalities of heart disease. And if you can detect it and treat it, you can completely stop progression of heart disease in any individual. If somebody already has permanent structural changes to your heart causing stiffness, then that diastolic dysfunction pattern, a lot of patients are having shortness of breath, but they aren't sick enough to be in clinical heart failure, nor is their resting echo abnormal enough. Those patients show up as low peak stroke volumes in our test when they have a otherwise normal echo, so we can clearly identify and treat these individuals, as well as pulmonary circulation abnormalities. This slide demonstrates how these different mechanisms are not equally distributed. Effort-related causes are about 10%, but so that means in 90+% of the patients we can typically get good diagnostic data based on effort alone. Obesity about 4%, and even the heart and lungs, you would think there would be a lot more lung disease. We only about 3 to 4% of the exercise limitations in symptomatic individuals are actually from the lungs. So the likelihood that shortness of breath is primary lungs is actually low pretest probability wise. What we see the most of is primary cardiac impairments that fall into one of these 3 categories. If their myocardial function is normal or cardiac output is normal in early exercise but decompensate in late exercise, that's an inducible ischemic pattern that can be from micro plus minus macrovascular disease. About half of those individuals show up here. The ones that have diastolic dysfunction with normal echoes, about 10% of those fall there, and about 18% are severely blunted heart rate responses, which most of the time is medical patients in need of medication adjustment. So atherosclerotic heart disease is a chronic inflammatory process which initially causes microvascular dysfunction in the form of either endothelial dysfunction or non-endothelium dependent increased in microvascular resistance, which results in a decreased coronary flow reserve. These are microvascular changes that are detected by CPET and can present as atypical symptoms, which is typically seen more in women than men. How this test is different is a lot of times this CPET is abnormal when patients have normal stress echoes, normal nuclear coronary angiograms, normal coronary calciums, as well as carotid interval thickness, which are markers for large vessel disease. So if you can cleanly detect a small vessel disease, you can pick up ischemic heart disease that's being missed by that's not macrovascular in nature. And most of the the volume of blood that the heart muscle actually sees is auto-regulated at the small vessel level. The large vessels on the surface of the heart, they're just conduits, and they don't really auto-regulate. So this dysregulation and auto-regulation is the early markers of atherosclerotic heart disease. So to demonstrate the importance of recognizing and treating microvascular ischemia is that it eventually leads to both symptomatic obstructive and non-obstructive CAD. It leads eventually to atrial fibrillation, heart failure, and if the person gets revascularized, it's going to persist as angina. So, and the biggest problem is chronic ischemia causing continuous left ventricular remodeling, which causes slow gradual stiffness in the heart, which eventually would show up as heart failure preserved EF. So this is a very vicious cycle, and 1 out of 3 women dies of heart disease, but a lot of them are not showing up with big MIs. They're showing up with diastolic heart failure as the primary reason for clinical presentation. So with CPET, we can detect the microvascular ischemia. We can see the severity of the disease and how low the peak stroke volume is. Low is bad, high is good. And peak VO2 being the #1 prognostic indicator will tell us whether the individuals are getting better or not over time, making sure the healthcare trajectory is in the right direction. Just to re-emphasize, this is a heart rate, blood pressure and heart rate, an EKG monitoring test that measures oxygen uptake with the mask in milliliters per kg per minute. It's an indicator of cardiac output per the Fix equation. Peak VO2 approximates peak cardiac output in the vast majority of patients. We're measuring CO2 production, which is an indicator of pulmonary perfusion dead space and tells us whether or not lung perfusion is a issue during exercise as a primary mechanism, as well as minute ventilation, which is used to measure both the maximum voluntary ventilation prior to the test and breathing reserve at the end of exercise. So individuals that do not develop a good metabolic acidosis and run out of breathing capacity or use up their MVV are indicated as having primary ventilation impairments. CPET is a symptom-limited test with a customized linear ramp. The first 3 minutes are at rest, the next 3 minutes are unloaded cycling, and allows us to take in the physiological impact of obesity and exercise impairment. And at the 6-minute mark, the patient starts cycling, and they keep cycling until they can't maintain an RPM of 60 anymore. So it's electromagnetically braked, and every 20 seconds it gets harder and harder to pedal. And based on how linear the ramp we chose, most patients will get between 10, 15, 20, 25, or 30 watt ramps. The volume of oxygen that's going into the body at the top of the hill, and that's our peak VO2. Peak VO2 is considered as cardiorespiratory fitness, a vital sign for chronic cardiac care, #1 predictor of all-cause mortality, and is inversely linked to a multiple of medical conditions. So as a marker of cardiorespiratory fitness or exercise capacity or functional capacity, most individuals should be 85 to 90% or higher of their percent predicted VO2. If they're below 50%, those individuals have the worst outcomes and the highest cost of care. Most individuals will be asymptomatic and in the middle usually between 60 and 80%. Those are the ones that need to get identified and have their risk factors addressed to help start pushing their VO2 back in the correct direction. What the data shows is not only is all-cause mortality inversely related to VO2, so is cardiovascular disease-specific causes, cancer, kidney disease, dementia, depression has been related, osteoporosis and falls, and including the severity of pneumonia. So the higher your baseline peak VO2, the less likelihood of catching pneumonia. And so that's been published in data as well that's linked pneumonia severity directly to VO2. And every single disease state is always inversely related. High VO2 is good, low peak VO2 is bad. So it's pretty obvious that the lower your VO2, the more heart and lung disease you're going to have, the higher your cost of care is going to be. So in terms of quantifying the relationship between exercise capacity or peak VO2 and actual cost of care, that's been done in a few studies. And the bottom line is, if we can increase VO2 by 5 mils from baseline, which is not a huge amount, maybe 20% for most people on average, you can decrease cardiovascular events by 23%, cancer-related deaths by 20%, and the annual cost of care drops roughly $2,300 per person per year. So increasing VO2 saves money. That's a good way to quantify the relationship between the two mechanisms. The last two slides will look at a normal and abnormal cardiac output response. A normal response is demonstrated on this slide with a 26-year-old healthy female firefighter and no risk factors. Her exercise capacity is good at 108% predicted, but one step further we go to is we dissect out the stroke volume and heart rate response in real time during exercise. So VO2 is a function of these two lines. If we divide VO2 by heart rate, we get a derived parameter it's a surrogate for a stroke volume called the oxygen pulse. So the blue line is the oxygen pulse, the black line is the predicted value. In a normal individual, the oxygen pulse or stroke volume should continue to rise in a normal linear manner before and after the anaerobic threshold, the green line here, right up to the end of exercise. So this is a recovery phase right here. Linear, this is the start of exercise. This is when she becomes anaerobic in the green line. And at the end, the other last black line is the end of exercise. So normal linear rise in the, actually I should be using a marker here. You got a normal linear rise in the stroke volume response, and in a healthy individual, as you start to get to higher and higher heart rates, and as you approach your true peak cardiac output, the heart rate can no longer sustain its increase, so it actually starts to slow down as it approaches true peak heart rate. So it's a negative slope on the heart. It's linear with a negative end at the end of exercises, typically in less than 0. And then the stroke volume response should be linear without plateauing and without a decreasing pattern in late exercise. So you can see in an abnormal test, what's happening is that this is the start of exercise. This is the green line is the anaerobic threshold. At some point between the AT and the end of exercise, individuals that have an ischemic burden from microvascular dysfunction or macro or both, what happens is the stroke volume rises linearly in early exercises, you can see here, but at a specific point when the oxygen supply-demand mismatch occurs within the coronary circulation, the heart muscle starts to stiffen, as a result of which the stroke volume response starts to decay with increasing work rate. And as a compensation mechanism, since cardiac output is a function of stroke volume and heart rate, when one cylinder fails, the other one starts to accelerate as a compensation mechanism because it's trying to maintain that cardiac output in a linear manner to the end of exercise. So if the heart rate response goes up over 20%, that's typically pathological, indicates that there is undertreated ischemic heart disease even in asymptomatic individuals. So in this person, you can see there's a 205 or greater than twofold acceleration in the end of exercise compared to the middle of exercise. So, and heart rate response is completely independent of stroke volume because they're being, in terms of measurements, one is VO2 dependent. This right here, heart rate is a function of time, is not. So you can see that the physiological or the pathophysiology and the compensatory mechanisms both take place at exactly the same time, showing how accurate and a hold the autonomic nervous system has over cardiac function in real time.
Okay, I'm going to go over a couple of case studies with you guys from patients in my office. The first one is a 57-year-old male who came to my office as a new patient this last August. He was an uncontrolled type 2 diabetic, had high cholesterol, he was obese, had a family history of coronary artery disease, but he was not a smoker. He presented to me complaining of chest pain and shortness of breath with moderate level of exertion. He had seen a cardiologist who wanted to order a nuclear stress test and CDA due to his neck pain, but he didn't want to have it done because he thought it was indigestion. He had no complaints with regular activity, so he wanted to address things with lifestyle medication instead of an intervention with the cardiologist. He presented to me already on Lipitor 40, aspirin 325, lisinopril 5 milligram for renal protection because he was a diabetic, not for high blood pressure. And he was taking Humalog 70/30 at the time. He gained weight on Humalog, so he switched to Soliqua for a time being before he started seeing me, which is a GLP-1 and basal insulin combo. And he started to lose some weight, but his blood sugars went back up, and so he switched himself back to Humalog 70/30 and was only taking 50 units once a day and not twice a day. He reported to me blood sugars between 200 and 300 throughout the day, according to his Freestyle Libre. And he also had a prescription for nitroglycerin to take as needed, which he did not need to use. I made some initial changes in his medications. First, I switched his Lipitor to Crestor, since this is a water-soluble statin and has often less side effects and more improvements in HDL. Kept him on his lisinopril for renal protection and his aspirin 325, but I switched his Humalog to a combination of Ozempic so I could maximize his GLP-1 dose and Toujeo for his basal insulin so that I could start off on a higher dose until we got his blood sugars under control, but then wean down over time once he made some lifestyle changes. I started him on Actos also because studies show that it lowers risk of stroke, it raises HDL, it lowers inflammatory markers, raises adiponectin, which is a cardioprotective hormone, and he had no complaints of peripheral edema and did not have congestive heart failure, so I didn't have to worry about these risks with the Actos. The goal eventually was to add an SGLT2 inhibitor later, like Jardiance or Farxiga, for the cardiovascular and renal protection, in addition to benefits on blood sugar control and weight loss. But I wanted to start off with this combination initially. I added the Vascepa 2 grams twice a day to lower triglycerides and to help with inflammation, in addition to cardiovascular protection. I added vitamin D, and then we also discussed extensively the importance of making some changes in his lifestyle, cutting back sugary, starchy foods, and implementing intermittent fasting. So I give him some information on this. I ordered a sleep study on the patient, which showed he had uncontrolled sleep apnea, an AHI of 29.1, which was near severe. So this was needed to be treated. And I referred him to a vascular surgeon for an ABI, which ended up coming back normal. And the vascular surgeon also ordered a carotid ultrasound, which also came back normal, showing no identifiable plaque obstructions. And then I ordered a CPET, of course, because of his shortness of breath. This patient's CPET came back very abnormal, demonstrating a severely reduced exercise capacity with a peak VO2 of only 50% of the predicted rate. You remember, peak VO2 is a marker of functional capacity, and it's like a global vital sign. So the higher the value, the healthier the patient is overall. Normal is between 85 and 100%, or it can be above 100, but once this drops below 70%, you're looking at more significant disease, most likely obstructive in nature. So on this graph, you see that top red line is graphing the heart rate response of the patient during the test, which should increase in a linear fashion as the resistance on the bike is increased during the test, and it does. That bottom line, the blue line, is showing the O2 pulse, which is an estimate of stroke volume, or how much blood is pumping out each time the heart beats. And as you see, this blue line increases in a linear fashion to a certain point, and then it flattens after the ischemic threshold. In this patient, that was at a heart rate of 121 beats a minute. And I explained to patients that this flattening indicates that the heart's struggling to keep up with the oxygen demands at these higher heart rates. So this information really helps us tailor exercise prescription based on each patient's individual cardiovascular health. And this patient's impaired ability to deliver blood and thus oxygen at the higher heart rates would put him at increased cardiovascular risk. So it was very important that he keep his heart rate in the moderate zone when exercising, which for him was between 107 and 116 beats a minute. So I went ahead and put this patient on a low-dose beta blocker on 25 milligrams of metoprolol so that it would help keep his heart rate down in the safer zone while he exercised. And for most patients, as long as their peak VO2 is over 70% and they can exercise in that heart rate zone without any symptoms, then a cardiology referral is not necessarily warranted. But this patient's peak VO2 was just too low, and he had too many risk factors and symptoms that put him at higher risk. And you see that EKG portion on his CPET was normal, so his cardiac dysfunction could have easily been missed on a regular stress test. But based on this CPET, I went ahead and referred him back to the cardiologist that he had initially seen. This time, the patient agreed to proceed with further testing now that he saw the results of his CPET. And coronary angiography with left heart cath revealed severe three-vessel disease. He did have a little bit of hypokinesis in anterolateral region of his heart, but he had overall preserved ejection fraction. A non-urgent CABG was recommended, which he ended up having done just a few weeks later. And you see in this slide the before and after blood work results. Between September and January, he had a significant improvement with his blood work and his cardiovascular function, as we'll see on his follow-up CPET in a minute. But this was even with a similar BMI. In September, he weighed 188 pounds. In January, he weighed 183. So he just lost a few pounds, not much, and still had a significant improvement in his overall health. The patient came back to have a follow-up CPET test done, and it showed a significant improvement, 21% in his peak VO2 from just medical therapy alone and from the improvement in his blood sugars. He had not even begun to exercise, and this is not from revascularization from the bypass surgery that he had done. This is from medical therapy. And this is what's so wonderful about the serial MET test reports. They're able to identify progression or regression of disease. And in this patient's case, the MET test company can put all of this data into an algorithm, and we're able to determine that he had a 25% relative risk reduction in just 9 months from medical therapy alone. And our goal is then to increase his peak VO2 continually to over 90%, hopefully in the next 2 to 3 years as we continue to work with him with his lifestyle also. So he had not been taking the beta blocker that I prescribed. So this follow-up CPET was even off of his beta blocker. This would look better if he was actually taking it. Since his resting heart rate in my office was consistently between 90 and 100, even though his blood pressure was normal, I did put him back on the low-dose beta blocker after I saw him for these test results. But this was a success story because this CPET correctly identified a high-risk patient that was in need of further intervention. And we know that even with patients with more advanced obstructive disease, CABG and stents do not improve long-term outcomes. Only medical and lifestyle interventions do this. So it's critical to optimize these therapies. And the serial CPET testing is what can help us track these improvements over time. So moving on to my second case study, this was a 45-year-old female who presented to me a few years ago with prediabetes, hyperlipidemia, including the genetic form of the lipid disorder lipoprotein A. And she was slightly overweight, and she had a family history of TIAs on her mother's side. She was a non-smoker, but presented complaining of some uncontrolled fatigue that had been ongoing for a while, and just some mild shortness of breath with exertion. And our only medications at that time were Cymbalta 60 milligrams a day. For this patient, we started off with a few initial interventions, mostly lifestyle related, but some supplements and prescription medicines. I had a long discussion with the patient about the importance of cutting back starchy and sugary foods because of her prediabetes and really implementing a regular exercise plan. The patient had recently started meeting with a trainer a few times a week, so I just encouraged her to keep this up. But I also started her on 15 milligrams of Actos and 1 milligram weekly of Ozempic to also help not just with blood sugars, but with appetite control and to help her have some success with her lifestyle changes. I started her on prescription vitamin D, 50,000 units twice a week because her levels were really low, 2 grams of omega-3, and I put her on 15 milligrams of L-methylfolate because she had an MTHFR gene mutation and her homocysteine was elevated at 9.7. Later on, I checked her B12 level, found that she was deficient in this because her homocysteine had gone up to over 13. But we started her on B12 shots every 2 weeks, and that came down nicely. So I ordered a sleep study on this patient because of her fatigue, which she did a home sleep study but failed it. So I'm still waiting for her to redo that so that I can assess whether or not she's got obstructive sleep apnea. But I also ordered a CIMT, which is a carotid intima media thickness test to assess the lining of her arteries to look for active inflammation or possibly early development of plaque. She did not have any plaque, but she had a significant amount of inflammation seen with her IMT measurement, which actually rated her at the time she was 49 years old, and she had an arterial age of a 66-year-old, which really confirmed the patient needed more aggressive treatment. The patient made many lifestyle changes and lost 13 pounds and still was complaining of feeling fatigued. So I ordered a CPET on this patient. She did have a little bit of shortness of breath with exertion, and it actually came back abnormal. It showed she had a peak VO2 of 83% of the predicted measurement for her, and she had inducible myocardial dysfunction at a heart rate of 117 beats a minute, which is usually an indication of microvascular disease or small vessel disease, and undertreated atherosclerosis in those arteries. And so this also indicates that she needs more aggressive therapy than just the lifestyle was helping with. Her CPET showed no EKG changes, no ischemia, no arrhythmias, which was a good sign. But this patient definitely had some more work to do. So at this point, I started her on CoQ10 to support mitochondrial health and cardiovascular function. And now we had to have a discussion at this point about adding a statin because her peak VO2 had come back to low, her CIMT was abnormal, her blood was abnormal. Even after lifestyle changes, we see, her functional capacity is lower than it should be. So the patient is heterozygous for a gene called SLOCO1B1, which means she's a decreased statin transporter and at 4.5-fold increased risk of developing muscle pain on a statin. So I only wanted to use water-soluble statins for this patient, only low doses. And so I put her on a low dose of Crestor, but she did not tolerate this. She also had myalgias on Pravachol and on Lescol, other water-soluble statins. But in the end, she did tolerate Livalo, most likely because this medication is metabolized through multiple pathways. And so she's currently taking 4 milligrams of this. And I have found with my other patients that most of my statin intolerant patients can tolerate Livalo, even at just 1 or 2 milligrams a day or sometimes every other day. But if she didn't tolerate that, I would have put her on the newer medication Nexletol, since that's a prodrug. It can't be broken down in the muscles, and so it does not cause myalgia. So that would have been my next option. But I also began treatment for her Lp(a), that genetic cholesterol that she had, which can accelerate early coronary artery disease. I started her on Enduracin, which is a brand of nicotinic acid, 500 at night, and then we bumped her up to 1,000 milligrams at night, and encouraged her to consider hormone replacement therapy to further lower her lipoprotein A. The HERS trial years ago with over 3,000 postmenopausal women who had a history of heart disease, and they were put on Prempro. And overall, this trial showed no cardiovascular benefit to using hormone replacement therapy. But in the subset of patients who had elevated Lp(a), the hormone replacement therapy did show a reduction in cardiovascular events. So that's why I would consider it in this particular patient if she didn't have any other contraindications. And of course, we discussed the importance of optimizing regular cardiovascular exercise in her target heart rate zone, as indicated on the CPET report, and not just weight training with a little bit of cardio, which is really what she was doing. Her before and after blood work 5 years later shows a significant improvement on medical therapy in her cholesterol and even the inflammation marker, Lp(a)2. Her CRP was normal, but the Lp(a)2 can be more vascular specific marker, and that was greatly improved. Her A1C was dropping, blood sugar, a great improvement on the adiponectin, which is that cardioprotective hormone. I see that go up often with Actos, and so it was certainly benefiting her based on her blood work. Patient did a follow-up CPET a few years later, and we can see that she's had an improvement in her. This patient did a follow-up CPET a few years later, and we can see that she's made an improvement in her cardiovascular health also, which equates to an actual 16% relative risk reduction in an event over the next 3 years. And this was just from lifestyle and medical therapy. She had a 14% improvement in her peak VO2. You can see these comparative reports. That top line is the first CPET value, and the bottom arrow on each line is the more recent CPET report. So you can see it comparing kind of apples to apples. So in this case, the patient achieves an increased peak cardiac function due to increased peak stroke volume with a similar peak heart rate. So this is actually showing she has improved her left ventricular function. But she did still have some mild dysfunction, so we will continue to push her until she reaches her personal best and redo CPETs annually at least to track her progress. In her case, her peak heart rate was at 85% of the predicted max, which indicates she could have tolerated a beta blocker if this was needed. But since she was able to exercise in her moderate heart rate zone without any problems, this was not necessary in her case. But our goal with this patient was to continue increasing her peak VO2 by at least 10% or more with each follow-up CPET test that we're doing. And if the patient wanted to be more aggressive, we could have added an ACE or an ARB to also help target endothelial dysfunction, because RAS medications can help open up the microcirculation and improve cardiac contractility. Or a more natural option, if you didn't want to use prescription therapies, would be Neo40, which it's a supplement that can improve arterial function and circulation through nitric oxide production. We used to recommend L-arginine as one of the natural approaches, but it's a little bit more difficult to dose. They don't have extended release forms, and so the Neo40 seems to be a good natural option. The nice thing about the CPET recommendations also for patients, it's the gold standard for exercise prescription, so it can help identify which patients can safely exercise at higher intensities, or those interested in HIIT, versus those who might benefit from more of the moderate intensity. And I typically recommend patients exercise at least 30 minutes or more a day in that moderate intensity zone. I encourage them to get a Fitbit to monitor their heart rate to make it easier, because there's a difference between where the heart rate should be if they're standing up and walking, weight-bearing exercise, or if they're sitting down cycling, the heart rate's going to be maybe 5 or 10 points lower on average. But overall, this case study was also a good example of a success story with medical and lifestyle therapy. We see the improvements tracking over time with her peak VO2, correlating with decreased cardiovascular risk. And so it indicates a good example of how CPET can be helpful in identifying patients that have some cardiovascular disease, maybe small vessel, maybe it's not, wouldn't be identified at a cardiology office or with some of the other mainstream testing, and how we can recommend appropriate lifestyle and medical therapies that can get them on track and reversing any existing disease before it becomes more problematic.